Okay, we will go ahead and get started here. Hello, everyone. I'd like to welcome you to the 8th in our series of 10 webinars that the Oregon Office of Rural Health is hosting, focused on critical access hospital finance and operations. Today's webinar is How to Build Revenue Front-End Competencies. I'm Sarah Anderson. I'm the Director of Field Services at the Oregon Office of Rural Health. Next slide, please. And before we get started, I would like to go over a few logistics. The audio is muted and the video is turned off for all attendees. Please select the ellipses on the right of your screen to populate the chat feature. And you can use this chat feature to ask your questions anytime throughout the webinar. And if you run into any technical issues as well with the webinar, please put those in the chat and we will help you. For content-related questions, we'll monitor the chat and ask them of our presenter at the end of the webinar. You can also raise your hand by clicking on the hand button on the bottom of the screen, and we can then unmute you so you can ask your question live. The presentation slides and recording will be posted shortly after the session on ORH's website on the link on the slide, and I'm going to put that link in the chat in a moment. Next slide. So as I mentioned a moment ago, this is the 8th in our series of 10 webinars focused on CA finance and operations. And you'll see the next 2 webinars listed on this slide. You can also find more information on the ORH website that I'm going to, with the link that I'm going to put in the chat in just a moment. And with that, I'm pleased to introduce our speaker. Carrie, if you'd move to the next slide. Great. So with us today is Carrie Bova. Carrie has over 15 years of experience managing revenue cycle operations. She's an expert in optimizing revenue cycle operations and improving cash flow in rural healthcare organizations. Prior to joining Wintergreen with the firm she's with now, Carrie worked for multiple rural organizations and was instrumental in successfully turning one rural hospital that she worked for over 10 years into a critical access hospital top 100 organization. So with that, I'd like to welcome you, Carrie, and appreciate you being here to share your expertise, and I'll turn it over to you now.
All right, wonderful. Thank you, Sarah, for that lovely introduction. To speak a little bit about what the topics of discussion today, it's really important that we recognize that the roles of some of our reception and registrars, it has really changed, and they essentially, given the industry evolving, have really become more of a front end billing component that is very significant. So today we're going to focus very specifically on how to build some of those front end competencies to improve revenue. So often I think improving the revenue cycle starts by evaluating your staff's perception of their role. Patient access, which there are different terms for throughout different organizations, but these are your reception staff, your central schedulers, the people answering the phone, even the switchboard operators. It's very different in many different rural healthcare organizations, but all relates to that one term, right? Patient access. And I think that in many times we really don't always celebrate and we don't share the impact of their role on the revenue cycle. And it has been proven they are often instrumental in reducing our expenses. They improve patient retention. They can result, their actions result in timely claim payment and customer satisfaction. We also know the challenges that we face with these high turnover entry-level positions. There is often frustration, incomplete understanding of their role, maybe inadequate training or continued education. In rural healthcare, we do see that a lot. We've had people that even if they haven't turned over are historically there and they're used to a process, and that process doesn't always evolve. And best practices in patient access really include ensuring the integrity of the data that we're collecting, because that is our one opportunity with patients, face-to-face encounter most of the time. So with that being said, we'll go over some observations that we've identified nationally and through multiple surveys from a patient perspective, and how that relates to what we want to convey in our organization. So, observations from a patient perspective. Do our staff areas appear organized and efficient? Are we timely and efficient? Do we see waiting rooms full of people and it takes forever? Do we have departments that say, oh, they've been sitting in the waiting room forever and I just went out and grabbed them? And then are our staff friendly and knowledgeable? If our any initial impression from a patient that identifies any of those observations are not favorable at your organization, it really can impact your entire revenue cycle, and it really can lead to a number of ongoing issues. Dissatisfied patients who decide to pursue their care elsewhere. That's the most important thing. As rural healthcare facilities, we must maintain patient retention to be financially viable. So any patient registration process is really instrumental in making that a first impression, a lasting impression, and a good impression of your organization. So we can really work on tweaking or building upon onboarding processes to really ensure that our staff that is patient facing have an immediate and pleasant impression on the patients, and really work on wait times and streamlined workflow so our patients are very satisfied with the care they receive in our organizations or clinics. Some of the impacts of not focusing on this: loss of patient retention. I think any patient accounting department would tell you that there is often a lot of claim rejections or denials due to the information gathered at the time of pre-registration or registration, or the lack of that information being collected. We face increased or additional expenses for lack of pre-service or point of service collection, cost to collect. We have vendors, a lot of us, for statements. We have submissions through clearinghouses that we may pay per transaction. We will have increased or additional expenses related to incorrect coordination of benefits. There can be compliance issues related to balance billing. And the most frequent thing we see is sometimes these things sit in that increased AR aging bucket, and it's very difficult to get those turned around timely. So as you look at what you're doing in your organizations, really focusing on patient retention as your main priority. Patient retention right now in an evolving market, it's really critical. And our patient satisfaction and retention efforts really begin with their initial experience. But it can also be a subsequent experience that we've improved on. The perception at every encounter in our organization is really critical to that continued patient engagement. And it's really critical to continued service and working towards service excellence. So that helps marketing too, word of mouth. So a lot of people often, scoff at this slide, and I will say it does seem very basic, but it does need to be looked at. And again, you're looking through your patient eyes. Are our patient access areas clean? Are they free from off-putting personal effects? Have we ever walked into a place and somebody has, it's like a bingo desk with everything all over? We don't want to give that perception in organizations, specifically rural healthcare. We're really wanting to compete with those larger health systems, and we want to make sure that everything is very organized and working in a professional manner and a professional perception. We also want to ensure that our patient access representatives are dressed for success, that they're courteous, they're friendly, they look like they want to be at the organization, they're willing, ready, and able to help. We want to work on reducing and automating paperwork for a more patient-friendly experience. So are we using electronic signature pads? Have you employed self-check-in or a kiosk if able? I just was at a clinic that has a kiosk. It's cut down their registration time by 3 minutes per encounter. 3 minutes is a lot in the eyes of a patient. Script the patient communications to ensure delivery of your organization's message is not misinterpreted and it's standardized. And what I mean by that a lot of times is we really want to make sure that we're scripting messages for pre-service collections, directions, anything that we do, we're creating a standard and consistent message. So no matter what portion of your organization they're calling, if they are getting a reception or a registrar, they're getting the same information all of the time. Working on establishing follow-up communications or random internal audits that determine patient satisfaction. How are we doing? How do our patients see us doing? And then really creating registration per counter stats and expectations. And what I mean by that is in a typical environment, it should take no longer than 5 to 8 minutes to register a patient. I'd like to see less, but if there are multiple things that need to be scanned, et cetera, it should not be more than 5 to 8 minutes. And are we checking that we are meeting that for our patients? Just like they track ED wait times, we also want to track the times our patients wait for services. Telephone etiquette. We want to ensure that all our patient encounters, even those that are non-patient facing, are really professional, that they're efficient and they're courteous. All calls need to be answered within 3 rings. Call transfers should be really warm handoffs to ensure no drop calls and appropriate connection. I've seen this multiple times where sometimes, you get that crackle and they hung up the phone or they transferred you and you hear that loud. A warm handoff, giving the patient the opportunity not to have to explain again. You become your organization, your registrars, your reception staff should become the warm handoff. They're talking to the department. They're saying, this is the gentleman, if appropriate. I mean, not in every situation, but the best we can do to give a really great experience and impression will really help. Don't leave patients on hold for extended periods of time, and routinely check in and explain if there are department delays that occur in transfer. So many people have noted on several surveys that, they get transferred to 4 different departments. Let's not do that. Let's see if we can get people to do that warm handoff and routinely check on that patient if we're on hold or we're experiencing difficulties reaching the right person to talk to our patients. And then really working on callback protocols to ensure timely and efficient management of the patient needs. These really work. And what I mean by callback protocols is, thank you for being here yesterday. We want to remind you that 4 laboratory tests were ordered and you can get those at one of our campus locations. We want to make sure there's no missed opportunity in revenue. So really driving the patients and making them feel super supported. So scheduling and appointment guidelines, I'm not sure if everyone is aware, but most payer contracts have appointment guidelines built into them for participating providers, network providers. We have to ensure, and I do know this, that we're starting to get mystery shopper calls in different areas of the nation to ensure that our processes for scheduling are allowing for timely and compliant scheduling per our payer agreements. So we do need to look at different ways. We can consider patient self-scheduling options to reduce lift on our existing workforce for some of those elective services. I mean, I know often we don't want anyone with a tummy ache or chest pain to schedule an appointment at our clinics, but we can make criteria for that to happen. Scheduling appointments in consecutive blocks and collaborating with ancillary departments really to ensure efficiencies and conveniences for the patient. Ensure that your organization has an appointment reminder system, whether it be text. A lot of people are moving more towards the texting and the confirmation. If you don't have one, that is a really great opportunity, or the voice calls from many EMRs reminding patient of appointments. And are they set within reasonable limits, right? It shouldn't be 7 days out, probably 2 days before the appointment. The other thing with those is you don't want to make them so inundating that you're frustrating the patients. we don't need to confirm our appointment 3 times. We just need to confirm it once, and we want to make sure we're only getting that call when we confirm within 48 hours of appointment. Collect data and ensure that verification of information no more than 48 hours in advance of a procedure or an appointment. So make sure we're double checking the insurance. If authorization was required, everything is listed on that authorization. I have encouraged some organizations with high no-show rates to explore double booking, but cautiously and strategically, and that will have to be a custom fit to your organization. And then really working on implementing work lists to ensure captures of add-on patients or for data reconciliation and accuracy. And one of the things I mean by this is so often we see this with CAT scans where a patient has a CAT scan without contrast, or with contrast scheduled. And then we schedule it, we get authorization for it, we have that, everything's great. But then the next day, because there may be an add-on or the provider may have decided to do with and without. Those are things that you really need to work on an author. If you have central scheduling or someone responsible for financial clearance in your organizations, really attempt to work on a reconciliation of the process, not just the beginning that we have it, but do we have the appropriate auth to ensure payment for all the services that we performed? That really is surprisingly efficient and preventing denial. So that's very important to take a look at. Sample appointment guidelines, I did want to talk a little bit about. So those mystery shoppers are calling. I'm not sure if everyone is aware, but there are in most provider manuals, and I just use Centene as an example. There are appointment guidelines, and if you are selected, if you're participating, you are required to make sure you're meeting these guidelines per your network agreement. So taking a look at your workflows and making sure that you know what your appointment guidelines are for your contracted payers, and that you have a process, if you can't accommodate, that you're documenting appropriately, that you're trying to accommodate your provider contract. So patient reminders, I can't say this enough, but I think I'm going to expand on the initial conversation about this a little bit. Those reminder protocols can mitigate those no-show appointments or late cancels. Many organizations or EMRs have what's called a wait list or a bump list that will allow you to potentially fill late cancellations. And there may be people in your local community that have been waiting for an appointment. This also serves kind of the reason I post this, the last slide, is it can also serve as a defense to some of those contract guidelines if you need to have it. Create a daily opening list for appointment slots available and communicate that to scheduling. Automated or manual reminder calls should occur at 5 days prior and again the day prior. And this is more for some of those very significant procedures or highly utilized clinics. So you can potentially get someone else in that slot and mitigate the no-show. Confirmation of appointments or cancels within the 5-day window really will allow for those on that wait list to be given an earlier opportunity. And this can create a revenue source for something that may be an otherwise complete loss for the time frame. If the patients cancel the day prior, consider a workflow where you're automatically rescheduling the patient. Create a nurse call list for no-shows to determine if care management minutes or virtual telephone encounters can be generated. And then establishing patient appointment protocols, if you've not already done so, to ensure that patients sign like an appointment attestation at least once annually. And in that attestation, you talk about your payment policies, your no-show policies, etc. And if you do not currently have one and you do have a high no-show rate, establish a no-show policy and bill no-show visits accordingly. There are ways that you can do that if you have a policy. So if that is something that any of your clinics or any of your hospital outpatient departments are finding, the no-show policy really can help, because the minute people start getting bills, they start coming to their appointments. Pre-service and point of service collection. We've seen this, through HFMA and NAHAM and AHAM for multiple years. We've seen that pre and point of service collections really are being pushed. And we see in rural facilities, and maybe not in Oregon, but in others where we really see that we could do better on those, or that we don't have a strong process in place for pre and post service or point of service collections. So really, it starts with appropriate and accurate verification of eligibility and benefits. And so many places use automated eligibility and benefits, and they think that's great. But do we really know what our out of pocket is for our patients? And are we communicating that? Pre-billing collection of patient responsibility really can significantly decrease the cost associated with collecting balances. And when we think about that, we have to think about bad debt, our early out statement vendors, the days in AR. All of those things can really be drastically improved by just creating a script and an expectation for our patients to pay at the time they come in. So really taking a look at what you should have received in point of service collections. I recommend, looking at remittance reports by location. The remittance code always identified PR 1, 2, or 3. If there's PR 1, 2, or 3 on any claim, then what did you collect against it if it was billed, and where are you in a percentage? And then really working on developing a follow-up work list for patients who were not able to pay at the time of service, for financial counseling, charity application, any opportunity to maybe enroll them in a health plan, get them involved, because when you enroll people in health plans that are otherwise self-pay or can't pay, if they get charity, I don't know, some people use underinsured charity. I'm not sure if that is a process that you are all using in Oregon. But there's uninsured and underinsured policies that you can build into your charity care workflow, where it may actually increase patient volumes at your organization by them having the peace of mind that it's not going to be absorbently expensive, or they're able to afford it, or they have a payment plan. So that is definitely something I recommend looking into. Pre-registration. So ideally, pre-registration should accomplish improved registration times, better patient flow, decreased expense to collect patient liability, and most importantly, a higher quality experience for the patients that really focuses on retaining them. And I often forget that I never put this in this slide, but also to market to them. It's one of the best ways of marketing in rural healthcare is word of mouth. If your neighbor tells their neighbor that they had a great experience, people really, it's like going to a restaurant. If you hear the food's great, you're going to go back. We want to give that real push in healthcare, especially in our rural facilities, so people want to come back and they're sharing their experience to generate more revenue and marketing at no cost with word of mouth. So again, I really focus on scripting, delivering the same message, a consistent message to collect that patient out-of-pocket liability prior to the patient arriving. And for those patients that are maybe coming into your healthcare organizations for surgical services and they have deductibles, asking for that deposit at the time of verification and pre-registration, it's very common. It is happening nationally. I think there's an uncomfortable level with some of the front facing or the phone facing staff that are collecting this information. And so it is also proven that when we provide that scripting, it really helps to move that along and get patients paying. The other options is really considering mailed questionnaires or direct software pre-registration through portals, telephone and in-person options to pre-register for all elective services in your organization, and then really working to create cross-functional workflows for collaborating facilities and campus locations. What I mean by that, if we have an ED and we're the PCP. So somebody goes to the emergency department in our main hub hospital, our main campus, but they're also an RHC patient. How are we getting that patient in? Are we creating a cross-functional notification or workflow to make sure that the clinic is getting that AIR for the ED follow-up within 24 to 48 hours? So there's a lot of opportunity to do that. At multiple department levels. So taking a look at that on collaborating and seeing what you can do to work as a whole health system is really a benefit to your organization. Registration, this is just what we need to do. But I really will tell you, I have not been to an organization in my entire career where I have not at least once heard, is everything still the same when someone is registering a patient? We really, really don't want to continue that if it is happening. Anything changed? We now have this real requirement under no surprises and with patient consumerism and healthcare to really collect as much data as we can to validate it and confirm it. And also to give that impression that we care. We don't want to just say, has anything changed or is everything still the same? Okay, you're checked in. Have a seat, Mr. Jones. No, with wait times, we do want to decrease them, but we want to provide a quality perception that we are here for our patients and we really want to validate their information. So those are some things that I really think just a walk in the shoes. I always recommend that. One day just take a look at your registration or your registrar areas and see what's going on and see if you can identify anything. At this point, in our careers, we should all be able to perform constructive criticism, but more teamwork and team perception. Identification of preventative service needs. If you've been on other presentations, you know that this is my pitch. I tell it a lot. It is really so important. We really need to start being better at identifying preventative service needs because they really can generate revenue. They don't generate patient responsibility, and they really improve moving us to readiness for value-based care. So start with your Medicare patients. Again, communicate preventative service needs to your nursing staff, however this works. See what works for your organization. And I have a little tip here. Look at your patient schedules in the next week. And those patients that are eligible for traditional Medicare, just run preventative service eligibility. And you can realize for your main organization a lot of money. So identification of preventative service needs. Here's an example. In reviewing one patient, 6 pages of eligible preventative service needs were identified. That totaled in, for this particular MAC, over $3,000 in just an impaneled patient that needed some labs and some different preventative medicine. And that all could have been received if we're monitoring our patient and we're building in those front end competencies so our front end staff know what to look for, know how to ask, and then know how to communicate that to people that can help make those achievements happen. So again, these are just some of the CPT codes with the eligibility dates, of course, patient information redacted, but really the benefits here are immense. All of these things are normal things that we would expect our patients to be getting anyway, but so many of them have eligibility dates that are years and years old because we have not appropriately made sure our patients are compliant with their preventative service needs. So one practice with 100 patients eligible for even half of these services could improve revenue without doing anything but screening and building in front-end competencies. 100 Medicare patients can gain your organization $20,000 on average. So that's pretty significant. Coordination of benefits. I think coordination of benefits is often not truly understood by some of our registrars, and it's not something that we typically train on, but it is very important. And so what coordination of benefits is here, but there's very specific rules that I've identified here, like the birthday rule, Medicare beneficiary hospice rules. Those are very important in our RHCs. And also in our RHCs, we can see hospice patients and bill for home visits for hospice patients effective January 1st, 2022. So we want to make sure that we're identifying that. And if it's our patient and we see that, we're identifying that there's potential to have additional revenues or to capture revenue for hospice patients that we would not have otherwise. Medicare secondary payer questionnaire. I know there are a lot of audits. There are a lot of facilities that often have had findings because they're not doing the MSPQ correctly. But really, that also helps to identify who the primary payer is, what we need to be doing, and in what order we should be billing insurances, which really can save a lot of denials and rejections on the back end. Compensation coverage is limited to a covered diagnosis. So ensuring that we have correct information relating to injuries, date of injuries, it's really critical to prompt payment. A lot of places I've seen where the ER comes in and they say, I hurt myself at work, and it immediately goes to workers' compensation. And we really, under the No Surprises Act, kind of have to pull back on that a little and say, you may be liable until we have a claim form, a claim number, we have a claims address, we know that the diagnosis that you're being treated for is covered by your carrier. We will register this as workers' compensation as a potential payer. However, this information is needed and conveying to the patient they may have a balance. And the reason ER is so important is even though it's emergent, patients have the right to know. And if we don't disclose things appropriately, they have the right to dispute through an independent dispute process. And we don't want to see that. We're trying to mitigate any compliance risk possible. So educating our front end staff to know what to look for workers' compensation and know the right scripting or questions to ask is very important. Medicaid is another huge one. Medicaid is always a payer of last resort. And much like Medicare, most Medicaid plans have information in the eligibility response relating to the coordination of benefits. And the accounts really must be registered accurately with the correct order. Sometimes we know the Medicaid system isn't updated, but if we're sending claims to them, we have to identify through claiming processes what was identified on the eligibility check. So this insurance really needs to be reflected to make sure that we have the correct coordination of benefits, just like Medicare wouldn't pay if the patient had an HMO. It's very similar to that scenario. Financial clearance, again, talks a little bit about benefit determination. Just because a patient is eligible for insurance does not mean they are eligible for the service that they are coming to your organization from. So making sure that your front end staff know how to do a benefit determination, not just an eligibility checked automatedly, is very, very important. Other things like beneficiary notice initiatives, CMS and the OIG are really, really cracking down on that this year. It's important to note. So are we doing appropriate tasks with delivering an ABN? Do we know how to issue ABNs? Do our staff do that? Do the departments do that? And are our staff able to speak to it intelligently if a patient comes with a question? Authorization nationally is just ever evolving every quarter, and we're seeing increasing pressures with financial clearance and the need for authorization. I do know there's some legislative changes out there we're hoping to get approved, but authorization as a whole is really important to make sure that we have it, that we're capturing it, and again, that we're authorizing all the services that we perform. So just making sure we have communication. We know that our contracted payer grid, someone is monitoring to see those updates. I believe, for example, and I'm picking on Centene today, and I don't mean to, it's just a good example. But so many payers are updating almost every 60 days, there's a code added. So really making sure that somebody is monitoring that the services don't require authorization is important. Referral management. So appropriate referral management and communication can really drive some of that ancillary patient service revenue, and enhance or build care management revenue. So establishing those preventative service communications to ensure you're meeting value and quality-based care requirements, but also communicating with nursing or provider staffs to ensure that preventative eligibility for your empanelment is addressed. And then many payers have what's called a payer non-compliance report, that is generated by the payers. And it tells you everyone that you have as a PCP on your empanelment and what preventative services they're lacking. And those are out there with many of the national health plans. And I'm not sure if every organization knows that, but getting that workflow to download that report monthly, making sure that your empaneled patient base is correct, and then that you're addressing the service needs that the payer has identified, that can really help to fill goals if you're fill goals, fill holes. If you're not meeting certain productivity requirements, etc., it really is a save all. So take a look at those. Check with your payer network representatives. Educate on your system service offerings and encourage scheduling through the system. So what I mean by that is, if you have multiple campuses, everyone may not know what your main hospital or sister hubs or additional service campuses can provide to the patients that they're seeing. So really educate on your scope of services as a organizational whole, and make sure that if that isn't just at an administrative and management level, but every end user again becomes your marketing tool, and they know the services that can be performed. And registration staff or patient access staff at checkout really should work on looking at collaborative campus scheduling or a notification. Hey, we had a patient here today. Doc ordered this at the checkout. Can we schedule that patient? Can we have them already scheduled? So we're now working collaboratively as a system. And you can also use checkout and referral management to enroll patient and care management programs. It is a really great opportunity because they come out of the window or out of the doctor, they come to the checkout window or registration area, and they've just heard all of the things they need to do better to maintain good health. So this is a really great opportunity to establish that scripting and get those members enrolled in care management programs that can generate consistent cash flow for your organization. So we talked a little bit about the checkout process, but again, it's just that second check, some of the opportunities that you can have there. I recommend, establishing checkout protocols to improve patient compliance with some of the services, making sure they're going to get their lab work, making sure they're going over to have their PT appointments. Consider providing charity care applications at the checkout as well to kind of help move that charity process along more quickly. Financial counseling, always do a 90-day look back on your Medicaid population if they were registered at self-pay. That is a huge report that we're finding lots of covered revenues that would otherwise be sitting in a self-pay bucket. So really do a 90-day look back and see if any of those people have become eligible for a managed care plan or a Medicaid plan. A bad debt review. Ensure that your patient access staff are thorough and they're competent with bad debt reviews. This normally occurs in financial counseling offices for best results, but making sure that you have a good Medicare bad debt write-off process, and maybe build in your financial counseling process to mirror the S10 worksheet, some of those types of things. And if anyone would like samples of that, please reach out to me after the presentation at the email. I'm happy to share, based on the 2020 Medicare bad debt changes, how I've seen that work in organizations where they're essentially getting the S10 worksheet filled out right by the financial counseling office for the majority of information. And then, self-pay management. It can effectively really, charity and self-pay management can really affect AR days. So it's really something that we should continuously focus on. And we really should build into our front end processes, having those conversations with those patients or deferring them to patient financial counseling. So questions and just to kind of summarize, because I know it's a lot of information quickly, but really appropriately addressing the front end can lead to multiple revenue enhancements that may not otherwise be organized. And it really can be done with minimal effort. You're not out there marketing for new patients, new services. This is really from what you have right now. How do you build revenue from what you have right now? And this is a way to do so. From decreased expenses to newly enrolled care management that's going to generate for your RHCs $77 plus a month, ancillary service revenues that weren't otherwise ordered or going to be recognized, really celebrating that patient access and front end staff are really integral to our organizations. They really have an evolved role, and we really need to focus on expressing that importance, educating it, and from a high level perspective, monitoring and improving and providing continuing education, because they are the face to the patient. They are the person on the other end of the phone most of the time. And we really, really need to focus more on making sure they're celebrated, making sure they're educated, and making sure that everyone in your organization understands their importance. And with that being said, I'll open it up to questions.
Thank you so much, Carrie. That was really great information. And as you said, we're entering the Q&A portion of this session right now. So as a reminder, you can put your questions in the chat box on the right of your screen, or you can also raise your hand and you can ask your question live. At any rate, taken together, all of the strategies that you shared make it really clear that there are a lot of opportunities for maximizing revenue. So out of the strategies that you shared to help folks get started thinking about this, what is the one place that you would focus on first to make some changes toward increasing overall revenue?
I love that question. So again, the preventative service pitch, really identifying that preventative service eligibility. It is breathtaking how much can be generated from a lot of just the testing that Medicare says we should be doing anyway. It really has no impact on the patient to schedule them for that. So I recommend putting that in their scripting. And again, I go back to that tip. I mean, if you want something that you can, that's tangible, that you can touch and realize right now, take a look at that Medicare preventative service eligibility for your patients that are scheduled next week, and find a way to get that communicated either via nursing, a billing alert or a provider alert in your EMR. It really is quite remarkable. And while the clinic itself may not recognize immediate revenue, but there are some things that the clinic will as well on that list. But your organization will, and that is very, very important. It just really works wonderfully to immediately capture that revenue. And then after that, I think I would really, if it were what I have seen be very successful, is really working on processes to kind of do that warm handoff to the ancillary department. So if you have a checkout process and you're doing a different EMR, maybe, the warm handoff process to follow up that a patient is going over to a clinic or to physical therapy, or they have and just a follow-up to make sure they're actually getting those done. And then the only other recommendation that I do know significantly decreases denials in multiple organizations, I've had testimonials of this, is doing the central or the financial clearance reconciliation reconciliation for the next day. Is everything that we performed in radiology and that we had authorized, did things change? And did we update? Because we have 24 hours to update the authorization. So once you build that reconciliation process in, you identify that there's a lot that happens that we don't know that happened at the time of scheduling. And we're kind of the gatekeepers and patient access of that information. And it really can significantly reduce otherwise denied lines on a claim, or total denials because there was a discrepancy or an acuity need that changed the procedure that we perform. So those are the top three, I think, that would really be great.
Fantastic. Thank you so much for that. And I should also mention to those of you on the call who have rural health clinics, our program manager, Rhonda Ann Gerst, offers a few webinars around billing and coding with Charles James throughout the year. And so please be on the lookout for that information on our website on the events page as well. That might be also helpful for folks. Another question. So at the kind of front end of the webinar here, you were discussing patient perceptions. And how those perceptions can really persist if someone had a poor experience for a really long time. And, can kind of spread throughout the community as well. You can have your good marketing, but then you're not so great marketing
You
when people don't have a
definitely
good
can.
experience. So what's your advice on changing perceptions? Let's say the facility has made changes to address some of the issues that they knew were going on that patients may have experienced several years ago, but people still have that perception and don't want to come into the facility because of that.
I think that that's kind of a multi-pronged approach. So if it depends on where the problem was. A lot of times clinical outcomes or clinical disagreements, I'll call them, do yield a bad taste in some of our patients' mouth. And to Sarah's point, they tend to share more frequently the bad than the good. So one of the things that is really great, again, with that, it's not just checkout, but it's follow-up calls. People can be mad at you for a long time, but they tend to soften if you're frequently checking in on things. So if they've had a bad experience, there was a hospital that I recently worked out with that did have a similar experience, and theirs was surrounding billing, and they essentially just updated their website and sent out mailers, and the theme really stuck with me. It said, "Entrust in us. We know we've made some mistakes in the past. To err is human. These are our new processes. We're going to offer routine walk-in appointments for financial counseling. Here's the number you can contact an administrator if you've been unsuccessful in resolving an issue with our organization in the past. Please call us. We will make you a priority." And a lot of that organization established a phone line and email, and basically they started to triage what the patient issues were. And once they did that, then you can make changes, right? You change by educating yourself on the patient perception and what you can do better. If we were all perfect, the other reminder that I tell every one of my organizations that I've worked with is never let it go. Like, never just say, okay, it was a call. If a patient calls and they complain about care, or they complain about billing, or they complain about someone they saw in the parking lot, the best thing that we can do is take that moment to put it in writing. Thank you. Every opportunity that you bring forth is an opportunity for us to improve. People really just want to be heard and understood. And there's a way to understand people and understand our clinicians. And a lot of times we can agree that maybe we have a difficult patient, but we can't forget this core value that I know many of us know from our grandparents. The customer is always right. Even when they're wrong, they're right. So we have to do our best to kind of navigate a very politically correct approach to how we communicate with them. And again, Sarah, I think this goes back to the scripting. Do we have standardized letters for every patient complaint that we send out that says, thank you for our opportunity to improve? Every time when something is identified, it gives us a resource to make sure that we're monitoring and improving. And it really can make a big difference, especially for those organizations. Sometimes there's mergers and acquisitions. Sometimes there is new management. All of those are opportunities to get that message out, that while we may have made mistakes in the past, it's a new day. And we're here for you, our rural communities. What can we do to improve? And that has worked wonderfully at several organizations. I've seen that work.
That's great. Thank you so much. So it's really about communication, but also kind of a little more deeply strategic communication.
Yes. Yes.
Mhm.
Scripting can make quite a difference with patient perception. I'm trying to find a way to measure it on some of the surveys with other organizations. But again, delivering the same message consistently to make sure that the organization message, to your point, Sarah, comes from a strategic, mission-based script as opposed to just letting people wing it. It really can help, and it really gives a much more professional, I guess, aura of what's going on in your organization.
Yeah.
So it's definitely helpful.
Great, thank you. I don't see any other questions that are coming up right now. So if you don't mind moving to the next slide,
I do not.
have a couple of announcements. And while you're moving to that slide, when you leave, when you click out of this webinar, you're going to get a survey that automatically pops up for you. And we really ask that you take a moment to complete it, as it helps us continue to bring you programs like the one we did today, and to make sure that we're improving them based on your feedback. And you also have an opportunity to earn continuing education credits by completing the survey. I'd also like to take a moment to share some announcements with you. On August 24th at noon, from noon to 1:30, we're having a special community conversations hosted by the Office of Rural Health, which is focused on our work to support Oregon's critical access hospitals and rural health clinics. So we invite you all to come to that and register, learn about the programs that we offer and the resources that we have for you. When you get these slides, the registration link will be in the slides, so please make sure that you check that out. Registration is also available on our website's main page as well. And then our ninth in the series of 10 webinars with Winter Green is on August 31st at noon. The No Surprises Act, which Carrie referenced a couple of times today, revenue protections and transactional compliance. So if you would join us for that, we would really love to have you there. Again, registration is available on the main page of our website, and we'll be sending out some marketing emails about the upcoming webinar as well. And then a couple of pieces around our annual Rural Health Conference, which is coming up in October. It's our 40th anniversary of the conference. It'll be held in Sun River, October 11th through the 13th. Registration is live. And again, if you go on our main website page, you can find the registration information there. So we are celebrating the last 40 years of our Rural Health Conference, and we really want to highlight the stories from organizations across rural Oregon that have contributed to health in your communities. Maybe it's a provider story, maybe it's a story of opening up a rural health clinic. Maybe it's a population health initiative that you put into place that made a big difference in your community. But if you would please share your stories. We'll be putting little vignettes up at the conference to celebrate all of the accomplishments around rural health over the last 40 years at the conference. So that is it for my announcements.
I love
And
that, Sarah. I'm sorry, but that is lovely. I think that's one of the nicest things I've seen and across the nation. I love that. Tell us your story. That's great.
oh, thank you. We're really excited about it, and we really, really hope that people participate in that because, it's all about everyone who contributes to rural health in our state, and we're so excited to celebrate that.
Absolutely wonderful. And I would agree. I think it really stresses the importance of why we need rural health care. So I'm looking forward to hearing more on that.
Oh, great. Thank you. And Laura, thank you for putting the link in the chat for the stories. If you have any, please feel free to click on that link. You don't have to submit them right away, but it's a pretty short form to fill out. We're not looking for essays. We're just looking for short vignettes. All right, so with that, I am going to close this out. Again, thank you so much, Carrie, for being here. Really appreciate it.
Thank you.
And I hope to see everyone on our next